however it happens, I think we know in this time of crisis, and these are the vulnerablest HIV/AIDS clients out there, they are in need of service, and to continue to add people to the waiting list and deny people comprehensive access and consistent access is a huge problem. And that's it for me. Thank you.
Thank you, Anne. Thank you for your flexibility in accommodating the Senator. And I want to just also bring up to date some of our staffers who are in the room. Last week, the ADAP Advocacy Association, along with 125 other national, state, and local organizations, sent a letter to President Obama, Senate Majority Leader Reid, and House Speaker Nancy Pelosi, asking them to either support Senate Bill 3401 or any other measure that would find this money to eliminate these waiting lists. It's my understanding that during the special order speeches this morning, Representative Alcee Hastings from Florida, a Democrat, went to the floor and asked for additional funding. Senator Bill Nelson from Florida, a Democrat, has written Harry Reid and asked him to do something about this crisis. And I'll just say one note about Senate Bill 3401, and I'm being politically aware when I say this. It was introduced by some Republicans, and this bill would take unspent stimulus funds to address the ADAP crisis. The idea, however, that was presented to the Senator Burr, when this bill was being formulated, was thought up by a self-described progressive Democrat who was well respected in the community, who understands from a public health perspective the importance of getting these drugs to people. He just happens to have a very close personal relationship with Senator Burr. So that, to me, brings us back to this has long been a bipartisan issue. I think that's evidenced by having both Representative Christensen here, as well as Senator Burr, and I'm hopeful that with some of the presentations you hear today that we can kind of get to that point and find a solution. But it's important to also understand from a public health perspective the importance of this crisis, and that's why we have asked Dr. Todd Wills to come up from Florida and really share with you from a medical perspective what we need, why this is a crisis that needs to be addressed sooner rather than later. Thank you.
I'd like to thank you all for inviting me. And we heard a lot about the funding shortfalls and the finances behind ADAP, but I wanted to speak today about the personal problems that our patients face and the consequences that they fear when they hear that they may be put on a waiting list or receive a letter that they have been. If we can look at the next slide. You've seen a lot of summaries of the waiting lists from the multiple states that had to create one. Florida has had a wait list for a relatively short amount of time. It was just instituted in the late spring and has enrolled people on a nearly 100-patient basis every week since the waiting list has been instituted. There are more than 1,700 patients on our waiting list as of last week. And when we break that down on a county-by-county and an urban center basis, more than 1,300 of those patients are in the 4 largest metropolitan areas of the state, which are significantly representing disproportionately affected groups with HIV/AIDS, including minorities. The true cost medically of ADAP funding shortfalls is in the medical outcomes for those patients who no longer can receive medications. It was previously a debatable issue as to whether patients required HIV medications early in the course of the disease, late in the course of the disease, and whether waiting a while would have a significant impact on their health. There were thoughts at one time that the longer you waited to place someone on medications, the benefit you would have is actually that they would have less side effects and less overall cost. But we've looked at this through federally funded studies, and the exact opposite has been found to be true. No matter when HIV medications are initiated, there continues to be an overall benefit for patients' health with earlier initiation of therapy, as close to the time of their diagnosis as possible. And conversely, in patients who are on medication, if they have discontinuations of their therapy or intermittent dosing, the consequences are much worse. This is especially true of many of the newly enrolled patients on the ADAP waiting lists. Many of them have come to our waiting lists because of loss of job or loss of insurance in the private sector. They had otherwise been taking their medications very regularly. Suddenly were referred by their private doctor to go to a county health department and get enrolled on the programs that existed there. And up until June, that was a feasible alternative in Florida, and it no longer is. In fact, many of those patients were in discussions with their doctor, trying to plan the best time that they could start treatment. They may have decided to start that in May when they could have been on ADAP drugs, but because they waited because it wasn't the right time for them, they no longer have access to medications at all. And it's a consequential decision that they really have trouble dealing with. The other thing we have to remember, we'll look at this a little bit later, when we aren't treating patients, it has a public health implication. Uncontrolled virus in a patient leads to a higher risk of transmission to uninfected individuals. And we have much greater success at controlling the epidemic when we can get people on treatment appropriately. We also need to get people appropriately tested. And when the hope of being on active medications is taken away from patients in high-risk groups, some of the same motivation to be tested and find out their status is taken away with significant implications. What you're looking at now is some data from a trial that was called the SMART trial, trying to figure out how late we could wait to start antiretroviral medications. And the take-home message from this, if you look at the solid line going through the middle, that is a point where the harm by a strategy of discontinuing medications or taking them intermittently becomes greater than the benefit. And across everything we measure for HIV, whether that be death from opportunistic infection, death from other causes, or other complications, whether they be cancer, heart problems, or kidney problems, people are disproportionately more likely to face those complications if they are not on continuous therapy or have discontinuations of their therapy. And it's a well-known, well-documented fact now. The things we're trying to study now are to figure out when the earliest, most beneficial time to start people on treatment is. But the loss of funding takes away that opportunity for our patients. This is true across all stages of HIV disease. We measure the strength of a patient's immune system by their CD4 count. And what we're looking at here is the risk of death or opportunistic infections, the infections that are most likely to afflict an HIV patient. Even those who are the healthiest are still 2 to 3 more times likely to die or become infected with an infection requiring hospitalization when they are taking intermittent or discontinuous therapy. Cancer risks increase as well, and we had talked about some of the costs of hospitalization. A patient going to the hospital for pneumonia or a retinal infection, that might be a $12,000, $25,000 hospital stay. When patients develop a lymphoma, one of the more frequent complications of untreated HIV, that requires therapy for an ongoing basis for 1 to 2 years. The cost may be more than $100,000 to $200,000. And the rates of development of malignancies in HIV patients are significantly increased when patients don't have access to continuous therapy. And that's represented on this slide by the green line, which are the number of patients who develop a new diagnosis of lymphoma when taking episodic therapy, as opposed to those on top who maintain continuous antiretroviral therapy because funding is in place. Let's look at the next one. I talked about the public health implications of ADAP funding as well. It is still true that most cases of new HIV infection are transmitted by people who are unaware of their diagnosis. Probably about 50 to 60% of new diagnoses are spread that way. However, about 40% of new diagnoses are spread by patients who are aware of their diagnosis and may still have detectable viremia and the ability to pass that infection on to a new individual because they're off treatment. If you look at these slides, the bars represent increasing risk of transmission of HIV to an uninfected individual as viral loads increase. Viral loads are higher and higher when patients are off medication. Many of our patients untreated have viral loads of a level that might be 50,000 or above. If you look here, they potentially have the risk of transmitting infection to an uninfected individual anywhere from 2 to 5 times greater than they would if their viral load was fully suppressed. So we are creating more and more burdens for our public health sector, more and more new infections with the personal tragedy and consequence related to that when we're not able to treat patients appropriately when they know about their diagnosis and are seeking care. Talked about this a little bit. Again, this is where our new HIV infections come from. A quarter of patients in our country are unaware of their infection, probably about 250,000 people in the U.S. They account for about 60% of new infections. But a large portion of new infections, again, are in those 75% of individuals who are aware of their infection. And within that group are those seeking and trying to get funding through ADAP and are unsuccessful in many of the most affected states. The other difficulty we face is referring patients to testing within the most affected communities, whether that be IV drug users, men who have sex with men, African American communities with a high rate of heterosexual transmission of disease. The CDC has advocated for widespread testing across risk groups and non-risk groups in the U.S. We really recommend now that anyone aged 13 to 64 have HIV testing as part of their routine health care. This is a very good idea. It recognizes many of those 25% of infections that we don't yet know about. However, much of the individual motivation to seek a diagnosis is taken away when we can't tell that patient that if your diagnosis is positive, we have comprehensive care available to you, including medications that can treat your disease. If I was to ask any of you to get an HIV test, knowing full well that whatever the result of that, I really couldn't offer you any treatment, there isn't a lot of personal advocacy or motivation to seek out that test and find out. You'd rather just not know than know something that you can't do anything about. Now, the CDC is still increasing funding for testing. I think the latest grant offer that they put out is for about $300 million to increase testing programs across the nation. But this is not coupled with funding to increase linking testing to treatment. And without that linkage, without a robust ADAP program across the country, little motivation exists to find those new diagnoses. And not only will known patients with infection transmit to others, but many of those patients who are unaware of their diagnosis will continue to be unaware and increase the rate of new infections and the eventual future costs that go toward treating that. So, from a medical standpoint, the consequences of lack of funding are severe. The risk to our public health infrastructure and control of this disease in the U.S. is significant, and I really do encourage all of you to do as much as you can to try to restore these shortfalls so that we can get back to the care of our patients. Thank you.